Thunander. I'm a physician in Växjö at the Central Hospital. I work with diabetes. Can you hear me better now? Yes? Okay. So I'm Maria Thunander. I'm a physician and a diabetes researcher in Växjö. Since Linnaeus University does not yet have a medical faculty there, I did my thesis in Lund University, to which I'm still affiliated, but most of the work is done in Växjö and with patients there. We are now collaborating with the Institution for Media Technology at Linnaeus University through Jenny Lundberg and Marcelo Milrad and the rest, and also with the eHealth Institute in Kalmar with Professor Göran Pettersson and Martin Karlsson and others, Lisa Eriksson. And I will briefly try to discuss what we are doing and what we would like to do when it comes to big data. And it's a question of new methods to collect, to store, and visualize diabetes real-world data. Selected randomized controlled studies will always just be relevant for that patient group, but then we apply the results in large everyday patient groups. And that's why now we have realized in healthcare we need to use more real-world data. And I can tell you that the need for handling of big data within healthcare is practically non-ending. It's enormous. So why diabetes? Diabetes is the most common chronic condition or disease worldwide in children and adults. It's the only non-infectious condition as HIV or malaria, TBC. It's the only non-infectious condition that WHO, the World Health Organization, has given highest priority to work with. It's one of few conditions that you can sum up in one blood test, in one figure, the A1C test, which we take every time the patient comes to healthcare. And this is very unusual and gives special opportunities to relate this to many parts of healthcare. So diabetes for many aspects is very figure dense, and it's extra well suited as a condition and as an area for the use of modern computer technology. So what is the problem then? The problem is that today globally 415 million people have diabetes. That's 8.5%. It ranges between 2 and 20 or 30 in some populations even. It's estimated in 2040 to be over 640 million people. It's a condition that poses extremely high demands on the individual. They can never take a break from the disease, which you can actually do in other conditions. It's a lot of self-care involved, and there are high risks of complications, blindness, foot ulcers, amputations, kidney failure, myocardial infarction, stroke, things like that, within 10 to 30 years if you do not take care of your blood sugar levels. The care of these complications involves high costs for society, and that's why we also try to put high costs in treating beforehand, because it has been established that you can either avoid or at least postpone these complications with better care and lower A1C values. And big data can be a great help to better understand a lot of these conditions, to store all these data and better visualize them. And we will see a little about that. What is diabetes then? It's a group of conditions where the plasma glucose levels are above normal. They are very strictly controlled in normal people, between 3 and 6, we can say. And if you lose this control, it's controlled by insulin, and it's produced way in here in the pancreas. And if this doesn't work right, your blood glucose goes high, and this has a lot of both acute and long-term negative effects. there are two main types of diabetes, and I think you should know this because we will be talking about different things. Type 1 is only 10% of everyone with diabetes. We used to say childhood, but we have shown in Kronoberg and other places that actually for every child who gets type 1, there are 2 grown-ups. So it's very much a grown-up disease, and you have it for all your life. And the care is so much better now that actually people survive into their 60s and 70s and 80s, which didn't happen 30 years ago. Type 2 is what you hear about in the press. Almost everything you hear in the press is usually about type 2. That's related to what they say co-colonization, or less physical activity, too much food to eat all the time, no starvation anymore. And this is about 85 to 90% of all diabetes. The needs are different because type 1 needs insulin for life to survive, while type 2 may need it to control the disease. And these are some examples of what we already have existing today as tools. You can see the new flash glucose meter out on the far side, which actually it's like having a 5 crown on your arm here that can sit for 14 days. And then you have something that's smaller than my phone, and you just do like this, and you measure blood glucose. This is fantastic. And you also get your number, you get the arrow, if you can see that, which is the last 5 values. So you will know if you are on your way up or down or straight in your values. And this will help the patient to know how much insulin to take for the lunch. And this is a revolution that has come to us within the last year. It's called flash glucose meters, and the Abbott one is the one that's available in Sweden now. Before, every patient, and still many do, had to make a fingerprint, take the blood, put it on a piece of paper, put it in a apparatus, and wait for some minutes before they had their value. Many didn't want to do that every time and in front of people, and so they didn't have the good control. What you can also see, Diascend it's independent program that has been developed, and it downloads values both from these new meters and from the old blood glucose meters of different makes. And these are the kind of curves that we now have and discuss with our patients. And you can see every little spot. This is a 1 month, 4 weeks worth of measurements. And so 1% generates this amount of data within just 1 month. You can multiply this and we have some big data. This is another example of what we have in Sweden. Sweden has the first national diabetes register. Only Denmark and Norway and some UK initiatives can compete, but we still have the best coverage and the most data that can be used. And actually, any one of you can go into the ndr.se and there's something called the button, knappen, and you can make these curves, and this is real-time data. The not full lines is for this year, 2000. Well, actually, this is an old one, but right now you can find for 2015 and 16, and you can compare, for instance, your county to the rest of Sweden. How well are we doing in how great proportion of patients have the low A1C values or low enough? How well are their blood pressures and things like that? And in Kronoberg, the healthcare region of Kronoberg actually won the IT prize for Swedish healthcare a couple of years ago for automatic transfer of data, and Kalmar has something like it. So there are good opportunities. We don't even have to go to the NDR to get the data. We can get it the back way from what we are sending there if we have the IT departments in our regions with us, and we have some of them already involved. So we have the NDR, we have electronic record systems all over Sweden now, and about 10 regions in Sweden are using the Cambio Cosmic from the Cambio healthcare systems. I still think it's the best one covering both hospitals and small practices in Sweden, even if at the moment we are not so happy because the last update was not the best. But otherwise, it has been quite good, and we have them in the project that we are now planning. What we need is better visualization of all sorts of data for use in the caregiving situation, visualization in the electronic records, for discussion with the patients and between caregivers, but also standard reports and things. Then, of course, we need also for research. And I just want to summarize the project that we are now planning and have started up. What are our previous experiences? And from the healthcare side, I can say that I had a student the other year who, or last year, who looked at every visit to the emergency department at the Växjö Central Hospital. About 75% of the patients had a blood glucose taken. It's routine. And if you look at just this one value when you come to the hospital, no matter if you come to surgery, to medical service, infectious diseases, no matter what diagnosis you get when you are leaving the hospitals or how long you're staying, actually this one value could predict if it wasn't within the normal range. The normal range is about 4 to 7 in this case. If it was 7 to 11, there was a 1-day median increased length of stay, and there was a shorter 30-day mortality or higher 30-day mortality risk. If it was above 11, which will give you an immediate diagnosis of diabetes, it was even higher values. It was 2 days more length of stay. And this is money, because staying in the hospital, even if you don't take one test or do one x-ray, costs now between 3,000 and 7,000 kronor each day. And we had an abstract at the ADA last year on that, and it will soon be submitted as a publication. Martin Karlsson, sitting over there, has a publication on vitamin D in Kalmar, which also uses big data, I understand. And I have worked with the KIMS database, which is the world's largest pharmacoepidemiological database. And we had 3 publications a couple of years ago on that. So now we are starting up. We have sort of 2 parts of our project with the media technology department, and one is more collecting data from patients and using this, but the other one is more on the big data side, and the needs are enormous, so it's just a question of narrowing down where should we start. But we have identified a project. We talk a lot about A1C values being too high, but there is an idea that have originated from Kalmar and Martin and Olof Berneld, looking at the low A1C values and using big data analysis, where you can now get so many more types of data into it, and we can see what does this have a meaning for health. Is it related to cancer, for instance, and different things? And we will use this as a pilot project where we learn how to use the data and how to better incorporate from many sources to get on track, so to speak. For the other type of the project with real-world patient data, working with the electronic records, but also with patients and personnel and better care situations, we are planning an ethical application right now for the first collection of data from young patients, young adults, and also we may put these kind of flash meters on old patients in old caring homes, because diabetes has a lot to do with being ill, and in the elderly, 20% have the condition. And we can see, we have some indications that they may be overly treated to too low values, and then they may fall and they may break their legs and so forth. So there are many ways you can utilize this, and just putting systematically meters on a number of persons and collecting the data. And in this way, we will get a fast input of data that we can provide for the media technology department to start developing methods to use the data. So this is the plan. Research questions then. How can big data from electronic record systems be made available in a better way and be better visualized to be used both for treatment and research? The second question, which are the most appropriate methods to collect and organize relevant information regarding diabetes? And there we're talking about flash meters, wearables. We have a wish for insulin injectors. If we could have a wireless communication with time points and sizes of doses, so we could arrange this together with the measurements of the blood glucose. And this is a new area that's opening up, new devices. And also do these things that these new devices actually lead to measurable improvements for the patients or the caregivers. The caregivers in form of time and so on, and for the patients better medical results. And there we can measure the A1C levels, which is, easier than in most diseases. And we have other measurements as well. And also, of course, quality of life instruments. And I think we have already talked about this. This is the group that's working together now from the media department and from Kalmar and Kronoberg, and we also have some companies involved, and the eHealth Institute. We have also talked to the diabetes patient organization, which have said that they support this and they are ready to help us get in contact with patients if needed and so on. External partners apart from outside of the Linné University, it's the region Kronoberg, region Kalmar, healthcare regions, the Diascend company, which is very crucial since they have this application already for collecting the data from different kind of meters. Cambio Healthcare Systems, since that's what's used in our regions, and could we find collaborative ways? And they have declared that they are very interested in this. We have also had some discussions with Abbott, who has the meter. Now, of course, the whole world wants to work with them. And Novo Nordisk have been very interested as well, an insulin company. This is just to show you, we have a plan. It goes on for about 4 more pages, but we have started with a time plan and who does what. Thank you.
Thank you very much. Before we continue with questions, I would like to ask those of you who are working with this project if you could stand up and briefly introduce yourself, just so that we could then use the breaks to talk more with each other.
Jenny Lundberg, Senior Lecturer at Media Technology.
You are contributing with?
Yeah, media technology competence. So I'm applying it and, writing applications and meeting patients and all this. Thank you.
Lisa Eriksson, Senior Lecturer at the eHealth Institute. I have a background as a pharmacist, and I will also do some health economic analysis.
Ilir Yusufi, Media Technology Department. I will be involved in visualization aspects of the project.
I'm Martin Karlsson. I'm associate professor here at Linnaeus University and also endocrinologist and clinical chemist here at the hospital. And I'm, of course, very interested also in the diabetes part and the big data part. So I'm going to work with that.
And you're also connected to the eHealth Institute, aren't you?
I'm Sonia Bellore. I work with the Department of Marketing, and I'm indirectly connected with this project since we're doing a comparative study with India on the use of mobile applications for children with type 2 and type 1 diabetes.
And I'm Göran Petersson, head of the eHealth Institute. I'm a physician and try to supervise and connect people. So I'm a sort of matchmaker. So I hope some of you from the industry sees the opportunities now to collaborate with the clinicians with all the data. Thank you.
Okay, thank you very much, everyone. Any questions? Marcelo. How could I forget you?
Hello, good morning. My name is Marcelo Milrad. I'm a professor in media technology, and we have been working with these ideas and in this project for more than 1 year now.
No, half a year.
With Jenny, even much more. And my contribution will be a little bit in conceptualizing these ideas of new ways of data collection, processing, and visualization to try to find new ways of interacting with medical information and to promote new ways of patients taking care of themselves. And as I'm also quite active international, I see one important role to disseminate and to create networks of people that are working in similar ideas outside the Nordic countries. So I have some contacts recently with the World Health Organization, and maybe we will run similar workshop in this direction in Latin America. Okay, thank you.
Well, one thing I didn't say was that the clinical partners, we have been working with clinical research for 20 years, and so we have a network in southern Sweden, nationally and even internationally. So when the need comes to scale up things, there are possibilities.
Okay, we have 5 minutes for questions in the audience.
I have a question if no one else has a question. Is it possible for anyone in the room, if they're interested in joining the project or cooperating? And if so, how would they go about doing it?
I would say that the first you could do is to contact Jenny Lundberg, who is project coordinator, but you can also, of course, contact any of the rest of us.
Okay, we can continue with the questions during the break, but we still have time for 1 or 2 more while we transfer to the following presentation, as we have time. So we will have a break after this presentation, according to the times given in the schedule.
I can at least comment that it was very interesting. We had some sessions yesterday too in the workshop, and as I said in my talk, the need for better use of computer technology in the areas of healthcare are very great. So there were many things that I thought might be interesting.
From the technical perspective, what are the greatest challenges for you? Is it the volume of the data, or is it variety of the data, or is this availability of data, or legal issues? What are the hinders now?
Availability and presentation, I think, are the largest, and then come the volume, I think.
Also, just to add, and also one important issue is if we conceptualize the idea of bringing patient-generated data that is associated with this particular disease, like for instance, what type of food people consume and how it impacts the glucose doses, we can do some analysis to do some predictions. And this is, to the little knowledge I have yet on the field of diabetes, does not exist. The possibility, but using historical data from patients to be able to predict behavior.
That's very true.
So this is also one.
To incorporate, as you are getting into food intake, since intake at every meal and between meals will affect the blood glucose. physical activity before and after the time that you measure glucose and the time that you take your shot, and also your emotional state, because stress will give an answer of cortisol and adrenaline in the body, and that raises blood glucose. So if there were quick ways to estimate this and to collect data, preferably as much as possible automated collection, and of course then to predictive models for patients and for groups will be very interesting. It's, you know, it's so new we can't even formulate it.
I just want to add a little bit to what Diana said, that this is one example in one particular disease that this approach could be applied, but there are already some examples in other diseases, like in the field of asthma. Glaxo and people from Stanford have been doing similar things, adding metadata. For instance, when you take an intake of an inhaler, then you have location, then you generate a lot of data at the level of big data, and then you do cross-match with environmental data to predict which features may impact asthma attacks and this kind of thing. So this approach of using a lot of data, collecting, predicting, and bringing data generated by patients may have some influence in many other domains. This is just one.
Absolutely.
Sorry. Now we have time just for one question. A quick one, sorry. Yeah, okay.
Good morning. My name is Louise Oslund. I'm the Managing Director for Kalmar Science Park. We also host an incubator with many interesting startups, and we also have many established companies that could be interested in this project. My question to you is, this is a very interesting project in general, I would say. Would it be possible to open it up for less established, startup companies to have their point of view in a project like this, i.e. looking at designing interfaces or other things, or is the project more or less closed? Or
I think this would have to be discussed within the project group.
Yeah.
I dare not answer right like that. Maybe Marcelo.
I think it's an important part of this effort to try to connect research to education, to do research-based education. At least in our master programs, we have research seminars that are fully based on project-based work. So, for instance, in our master in media technology, we have a course called Advanced Research Topics. It's 200 hours of effort. So, if we plan this effectively, the companies could come with some challenge already sometime ahead connected to this project. And we face the students, and I think in computer science could be that the same. And then we have something quite tangible, but needs planning.
I can say we are very interested in interface in the healthcare area, so I hope.
Thank you very much again. Now, I would like to